Good evening, everyone. We welcome you all and thank you so much for joining us today for this webinar Women Driving Change for Heart, Brain, and Vascular Health. We are absolutely thrilled to have you all here today. We have over 300 people registered for this session, which is incredible. It really shows the momentum and passion behind this work. My name is Salima Allana. I'm an assistant professor at the Western University in London, Ontario, and I'm delighted to be your co facilitator today with my colleague Monica Perry, who is a professor at the University of Toronto. Thank you again for being here. We are really looking forward to a great session together. We would formally like to begin the webinar with the land acknowledgement, acknowledging the indigenous peoples of all the lands on which we are gathered today. While we meet in a virtual space, we recognize that we are visitors on these lands and take this moment to reflect on their significance. Acknowledging the lands we each call home is an important step in reaffirming our commitment to strengthening relationships between nations and deepening our understanding of local indigenous peoples and their cultures. From coast to coast to coast, we honor and acknowledge the ancestral and unceded territories of the Inuit, Metis, and First Nations peoples who have cared for these lands for generations. Please also remember that any information shared with you today is not to be considered medical advice or substitute for any medical professional help. Always speak to your doctor regarding any questions you may have about your health. This presentation is intended to increase awareness about heart disease and provide you with key points to start the conversation with your provider if needed. Before we dive into the webinar, we want to take a moment to ground today's session in what we have accomplished together so far through the Crowning Us project. Cardiovascular risk across the lifespan with women, intersex, gender diverse, and other underserved people in Canada. This work brings together a group of passionate members committed to amplifying the voices of all women and gender diverse people across Canada and ensuring they are centered in conversations about heart, brain, and vascular health. Here is a quick look at what we have done to date. On April 23rd this year, we conducted a national workshop. We brought together community members, researchers, healthcare professionals, and people with lived and living experience to identify early gaps and priorities. On September 10th, we conducted a national webinar, Pregnancy's Hidden Impact, Cardiovascular and Dementia Risks. This session is available online and you can watch the recording anytime on YouTube. Today, on November 27th, we are right in the midst of this webinar, which is a continuation of our shared learning and community engagement work as we broaden our focus across the lifespan. February 2026, we have planned for our upcoming Crowning Us workshop right in the month which is known to be Women's Heart Health Month. This workshop will further engage underserved populations across Canada to surface gaps, opportunities, and community driven ideas for future research and innovation in women's cardiovascular health. All of this work is building towards a more inclusive, responsive, and community driven approach to women's cardiovascular health. I would also like to introduce you to the team, including our partners and collaborators. This event is hosted in collaboration with the Canadian Women's Heart Health Alliance and in partnership with our community partners at the Council of Agencies Serving South Asians, CASA, and the Sickle Cell Awareness Group of Ontario. This project is led by Dr. Monica Perry, who is a women's cardiovascular health researcher at the University of Toronto. I, Dr. Salima Alana, am a co investigator on this project and I am an immigrant health researcher. Our team consists of many other cardiovascular clinicians and researchers who have expertise in various aspects of women's cardiovascular health, some of whom will be speakers tonight, such as Dr. Shaheen Jaffer, Dr. Naja Adrik, Ms. Sadaf Faisal, and Ms. Deborah Baden. We are also very fortunate to have our very dear and courageous women with lived experience who will be sharing their stories of courage with us today, including Ms. Sudi Bar, Ms. Suman Mohajan, and Ms. Oluwa Yimisi. Beyond the presenters today, our team consists of a wide network of passionate women working tirelessly towards improving women's cardiovascular health in Canada, and we acknowledge all of our team members here. We encourage more women like yourselves to join us at Crowning Us. You may join via the QR codes appearing on your screens. Let's move into the learning objectives for today's webinar. So, by the end of this session, we've planned that our participants should be able to learn simple, proactive steps to care for their heart, brain, and blood vessels. They should be able to hear from other women with lived experience about their stories of courage. They should also be able to get some answers from leading healthcare professionals and advocates around their questions. And they should be able to turn their lived experience into action that helps shape better care in Canada. Here is our plan for today. First, we have already begun with a brief welcome and introduction. Next, we'll move into empowerment through storytelling, where we'll hear powerful lived experiences from women across Canada. These stories will ground us in the real impact of heart, brain, and vascular conditions. We will then shift into start the conversation what everyone needs to know about heart and vascular disease. A short educational segment to highlight key facts and emerging evidence. After that, we'll open things up for our Ask the Experts panel discussion and Q&A, where we'll address the top questions submitted by the participants. Following the panel, we'll continue with talking about care, what works, what can improve, a discussion focused on gaps, strengths, and opportunities within our healthcare systems. And finally, we'll wrap up with a brief closing inspiration and next steps to share how you can stay involved in this work. We are so glad you're here, and we are really looking forward to a meaningful, engaging session together tonight. With that, I'll hand over the floor to my co facilitator, Dr. Monica Perry.
Thank you, Salima, very much, and welcome again, everyone. So now we're going to move to, I think, and our team thinks, a very special part of our session, empowerment through storytelling, lived experiences from women. This segment is all about hearing directly from women about their journeys with heart, brain, and vascular health, the challenges they face, the insights they've gained, and the ways they've been empowered to take charge of their health. We are so grateful that three incredible women have agreed to share their personal stories with us today. These stories are powerful reminders of why this work matters and how lived experiences can drive change for all of us. As our presenters share, I encourage you to listen openly and reflect on what resonates with you. These stories are deeply personal, and they highlight both the resilience and the diversity of experiences among women across Canada. After each story, we'll have a brief moment for reflection before moving on to the next speaker. Let's welcome our first storyteller and begin this inspiring segment. So, Sudi, may I welcome you?
Hello. Can everybody hear me?
Yes,
Yeah.
please.
Hi,
Wonderful.
Sudi.
Thank you so much for giving me this opportunity to share my personal lived story. So what happened for me and how I got into health advocacy, especially for women's health, is through my own personal journey, which started, I would say, incoincidentally through advocating for others. I was initially, before my own personal heart journey, was advocating for newcomers in the Canadian healthcare system. And I would often come in as an interpreter, being that I was a program developer at a nonprofit. And that's the perspective I had about healthcare. And then shortly after, time goes on, I get married and start my own family, planning to start my own family. Um, I was pregnant, I had a very easy pregnancy. Life was just, I was ticking along. It was like, this is what I'm going to do. I'm going to do a tummy wrap, have an easy labor, because I was a textbook description of pregnancy. No symptoms, weight was good, everything was wonderful. I ended up going to a low risk hospital because everything was going so well. Um, Textbook pregnancy, that phrase just stuck with me because that was every time I went in for a check-in, that's what I would get. Like everything's perfect, everything's good. But life, nothing really is ever perfect. So on the day of delivery, I this was my first pregnancy, so I noticed the other ladies, their babies were lower than mine. I was like, it's your first pregnancy. Some babies drop just before delivery. It is okay. And then when I went in for assessment, I was sent home the first time because um, I was not dilated. I had no symptoms, but it was the due date. So they're like, just wait a couple of days. I waited a couple of days. I ended up calling because I saw something that looked like meconium. I got brought back and they said, yep, that is meconium. We need to definitely do a delivery today and we're going to induce you. Through the induction process, we learned that uh, this is all hindsight now, but I got induced, ended up, and very soon through the journey, my baby dropped into my right hip. And I'm like, well, I'm induced and I'm lying down and I'm very petite. You can't see from the camera, but I'm like 4'11". So I had talked to the nurse about it. She's like, oh, that's normal. We just shipped the baby. And then later on, I found out because of my frame and the size of the baby, that was not possible. We had to do an emergency cesarean. And I only had like, what is it, half an hour to decide for that, if that's even an option. So yes, we went in with the emergency cesarean. And then I was like, please, as soon as I need my painkillers, give it to me. Don't wake me up. And because I just knew this was going to be an ordeal and this was my first surgery ever. So the whole idea of surgery was like mind boggling to me. Um, so we went in, did the surgery, had the baby, healthy baby, wonderful. Everything was wonderful. Still at a low risk hospital. And the next morning I wake up with extreme pain, the back of my neck, between my shoulders, can't breathe. Everything just feels very intense. I mean, my memory of that is just like, well, I didn't get my morphine this morning because I shouldn't feel this way. Everything should be, taken care of. Anyways, I paced my nurse, and the nurse tells me, yes, yeah, I gave you your morphines and painkillers at 6 a.m. And I was about 6:30, I was at 7 a.m. Nothing was working. They're like, you know what? Maybe you had an air blockage. This is normal for a cesarean. Go walk it off. And I'm trying to walk, but I just can't really breathe. And I'm in such excruciating pain down my left arm to my elbow, the back of my neck, between my shoulders. So I kept persisting. Can I please see my obstetrician? It's like, oh, she's teaching right now. She'll come in later on in the day to check on you. I'm like, okay. Nothing's getting better. So I persist again. Bing, 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 bing. Can I please see someone? Can I get an obstetrician? Can I see a doctor? Finally, they ended up, through persistence, South advocacy number one, they ended up calling the obstetrician. An obstetrician said, well, why don't you do an ECG? We did an ECG, which is not 15 minutes, 15 minutes, in a matter, I would say 15, 20 minutes, the entire hospital staff, which is a really small, small hospital, low risk hospital, was in my room. They're like, oh my God, we've never had this happen before. We have no room for this baby. You need to go into surgery. And I was just flabbergasted because I didn't really intend for anything, not that anybody else does. And also, I had no family in town just yet to even hand off the baby. So what? I mean, my husband was new to the country. Long story short, I ended up going to surgery, got a stent in. To sum it all up, that stent, and this is where women's heart health and research in women's cardiovascular health is so important. Is that what we end up learning 2, 3 months later on could have really changed the trajectory of where I am right now. That then ended up exacerbating my very frail heart, and I ended up having 7 more heart attacks. And at that point, the emergency hospital where the stent got done said, well, definitely we are at capacity. There's nothing more we can do for you. We're going to transfer you to the university hospital. At the university hospital, no amount of painkillers was working. Nothing was getting better. My heart function was deteriorating all the way to 3%. I had gone in with a perfectly healthy heart. Now we're at 3%. At the juxtaposition of this is too, there's not much to do except to get an LVAD. And an LVAD is a left ventricular assist device. So it's basically in your heart and it takes over the function. So you have no pulse, you have no heartbeat, and you're waiting for a transplant. I had that for 8 months, and in those 8 months, it was thankfully I was alive, but it was really difficult because there's so much of your life changes. You're sometimes the battery will die, and then that means obviously the machine will shut off, and there's nothing else backing that up. I ended up having a lot of TIA strokes. So, anyways, in that journey, we ended up having three. I ended up having three open heart surgeries with the LVAD and all of its hiccups. We got to the point that we had I went through an expedited transition to a transplant. All to find out because of the number of blood transfusions that I have had, the fact that I am ethnically was not born in Canada. I am not the majority demographic of the donors of the um, organs. Uh, it was the success rate was going to be 2%. And it was either to stay with the LVAD that would eventually will give up because it was just we're having so many hiccups with the LVAD, or to do a heart cath yet again. This would be now by the third one to see if anything had improved. Thankfully, I prayed and prayed, and really just I had nothing but prayers. And my wonderful team of physicians and doctors and medical support system there, we did the heart cath, and it was a 6 minute walk that I had to do to see if there's any improvement for my ejection fraction from the 3% to a functional rate. I ran through 6 minutes because my life depended on it. I had a brand new baby that I literally barely ever touched because I was in so much pain. And it was not the life I had planned for myself. So thankfully, I did make it through those 6 minutes. They went back and they did a assessment after the heart cath and saw that my heart function had come back to 40%. And that was mind-boggling. And in that journey is what we learned that I had suffered from SCAD, which is a spontaneous coronary dissection. That was the cause of my heart attack. Not obesity, not any other non-commutable NCD, but something that's under research, but has I think is a mortality rate of 80%, but a success rate, a survival rate of 80%, almost the same. And I was number 17 in Canada, and all because most doctors don't know about it. It's not fully researched. It's in somewhere in the textbook somewhere that later on we find out that this is SCAD and I'm number 17 in Canada. And since then, things have really changed. My story happened in 2017. And since then, through my recovery in the hospital and out of the hospital, I've been very dedicated to sharing my story because I just don't know a number of women that are going in with complications and sometimes passing away at delivery because of the possible SCAD events that happened. That was detected at home or in the hospital, and there was not enough time to really remedy because it's not in the forefront of caring for women in their um, pregnancy chapter. That is thankfully I'm here advocating, helping other women, and sharing my story. Since then, I've done a lot of speaking engagements, but my heart really is to change the statistics on the low research and on women's health, and pass it forward now that I have a second chance in life.
Sudi, thank you. Your story always is heartwarming to me, and it's so nice to see you doing so well. So I just want to thank you again. And you come to us from Edmonton tonight, so thank you.
Yes, everything. Yes, and this has been a
Yeah,
good land for me.
you're a big advocate, and just so people can sort of reflect on your story, your pregnancy, your heart attack, which was related to a sudden coronary artery dissection, you were placed on an LVAD, and just so people know what that is, it's a left ventricular assist device. So it is a device, and Sudi was very ill in the intensive care with this device. Luckily, your heart function resumed and you avoided a heart transplant. But, at a very young age, during your pregnancy, to be faced with sort of these life-threatening circumstances are I think, overwhelming. So thank you for all that you do, and thank you again for joining us tonight. So you're sticking around, which is great. So thank you. Um, I think we'll just move along, if that's okay, to Suman. Suman is from Ottawa, and Suman has a little bit different story than Sudi, a little bit related, and you'll see. But Suman, are you here?
Yes, I am.
Perfect.
Thank you.
Welcome. Thank you.
Thank you. Good evening, everyone. My name is Suman Mahajan, and I live in Ottawa, Ontario. I just want to let you know, today I'm just going to read my story, as this is my first time sharing my story with large audience. I call my story, Positivity is Core of My Life, and I live by 80-20 rules. Before I tell you about my heart journey, I need to share that I was diagnosed with breast cancer at the age of 47. This is when I leaned into my mantra, remaining positive with 80-20 rules. 80% is our attitude and 20% is whatever life throws on us. As part of my treatment, I had an opportunity to participate in a clinical trial where doctors were checking my heart function before and after my chemotherapy to make sure my heart could handle the chemo treatment. After 6 months of chemo, my oncologist discovered that my heart function had dropped significantly. I was referred to a cardiologist, and soon after, I learned that I had chemo-induced cardiomyopathy. I was told that now I'm in heart failure. Even with the diagnosis of heart failure, I went through treatment of radiation for 5 weeks. Prior to my breast cancer, I was otherwise healthy and strong, working full-time, wife and mom of 2. Overall, I responded well to my heart failure medications. For over 10 years, I was closely followed by the amazing heart function team at the Ottawa Heart Institute. Then in 2014, my health began to decline significantly. I was grateful that in 2010, I was given an ICD with the defibrillator, which I knew that it protects me until the whatever next step will be. By that time, my right side of the heart was also failing. My heart function at that time was working only 15%, and I was told that now it's time for a heart transplant. During the pre-transplant test, the doctors discovered that my lungs pressure was too high to support a donor's heart. I was admitted to the Ottawa Heart Institute for IV treatments and ended up staying for 5 weeks. The best option for me at that time was to receive LVAD, as Sudi mentioned earlier. LVAD is a left ventricular assist device to help my body to get stronger and preparation for the transplant. This was the time I felt feared the first time. 6 months after LVAD, I was officially put on a heart transplant waiting list. Getting on the transplant list was blessings and relief, and also was beginning of testing my mantra. My LVAD journey lasted 14 months, and I spent nearly half of that time at the hospital with various complications, as Sudi mentioned earlier. The staff at the hospital was extraordinary, not just the doctors and nurses, but every single person I met. They were caring, compassionate, and truly became like a family to me. Their kindness is something I will never forget. Even now, my husband volunteers at the Heart Institute, and many of the staff still remembers me and ask him how I'm doing. That connection, that sense of care means so much to us. My cardiologist once told me that I was overachiever, that I faced every complication with an LVAD I can, but I was ready for those challenges because of my mantra. Then came the day that changed my life forever. January 7th, 2016, the day I received my donor's heart. After my heart transplant surgery, I was in induced coma for 7 days and stayed in the hospital for 2 more weeks. Life after the heart transplant involved a lifelong commitment to medications, regular monitoring, and a healthier lifestyle to prevent organ rejection and manage side effects. Due to the high risk of rejection, during the first year, I had 12 scheduled biopsies, 10 in first year and 2 biopsies in second year. At the end of my second year, I faced rejection. Fortunately, I was able to recover with high dosage of immunosuppressant drugs. I know that long-term success depends on managing my medications and monitoring for potential complications like rejection and increased risk of cancer. Being on immunosuppressant drugs for a long time, I do worry about side effects regarding my gut health, kidneys, liver, and other complications. It sits in the back of my mind every single day. I just want to take a moment here to acknowledge the unbelievable, unconditional love and support I had received from my family and friends. My husband Ganga, 2 kids, Angela and Samir, their spouses, and young babies were at my bedside during those difficult moments. Even my brother and sister-in-law visited me every single day at the hospital. Thank you. Though I felt guilty that attention my family was given me, secretly my heart was filled with love and gratitude. I am very blessed with caring family and 4 beautiful, loving grandchildren now. I was also fortunate enough to receive a letter from my donor's family, which has given me peace and felt like a hug to me. That I carry with me every day, for which I will be forever grateful. And today, almost 10 years later, I am here, living, thriving, and deeply grateful for every single day of my life. Through this journey, we have changed our lifestyle. I'm still in work in progress. I live by 4 pillars. I live what I call the 4 pillars of a healthy life: good nutrition, movement, and regular exercise for healthy circulation, good sleep habits, and managing stresses consciously, mindfully, and with positivities. These 4 pillars have helped me stay strong, not just physically, but emotionally and spiritually. I share my story because I want others to know that they are not alone. Whatever your heart journey looks like, whether it's a heart disease, recovery, or prevention, please remember this. When it comes to your health, I encourage you all to listen your body's whispers. Take care of your heart health with healthy lifestyle and 80-20 rules, just like me. 80% is our attitude and 20% is whatever life throws at us. Thank you all for your time listening my story. That's all. Thank you.
Thank you, Suman. That was a very powerful story from breast cancer, chemotherapy-induced heart failure, defibrillator, a transplant, rejection, and recovery. And very powerful. And you have lived by really important pillars, and I think those are important to share with everyone. So I'll let everyone sort of reflect on your story. We've heard about advocacy, taking care of oneself, and the ability to receive care when we need it. And I think those are important points. So thank you. And let's move to our last speaker, but certainly our final speaker, not the last speaker. Alu, welcome to the
Thank
panel.
you. Thank you.
You're welcome. Now, I'm not sure if your camera's on.
I have it on, but somehow it was turned
Yep.
off. It's back
Perfect.
on. Thank
Perfect.
you.
Okay.
Thank you so much for having me today. My name is, good evening, everyone. My name is Oluwayemisi Abatom. I am a trained nurse, midwife, and public health nurse that migrated to Canada to seek a better career in nursing in Canada. But within 1 year, I got into Canada. I felt I was strong, but then I suffered stroke in my sleep. I slept and I didn't wake up because I had stroke in my sleep out of stress, nothing else but stress. I felt I was that actually before it happened that I slept and I didn't wake up. I was active, agile. I was the life of everything. I felt nothing was impossible. I was persistent. I would push well to my goal. I was a go-getter. I never relented on anything. That was the lifestyle I was living. I got here. I was working towards getting my permanent residency to pursue my nursing career, and I never stopped. Everything I was doing was to ensure I got the papers. I never knew I was kidding myself until the day I got home. I slept and I didn't wake up. I practically had stroke in my sleep, and I was there because I was living with a family that had gone on vacation. Nobody knew I was in that condition until people at where I was doing my co-op to get my papers said it is so unlike me that even if I was going to be late, I was going to call to say I was going to be late. But in 2 days, not showing up and being called not responding, that something was wrong. These were the people that ended up coming to look for me. Now, what happened was that I had stroke in my sleep, and because nothing happened, the stroke continued. And by the time I was found, I was already unconscious, just with pulse. I was rescued by the emergency service of the police, fire, and the ambulance. At the hospital, they did their blood work to find out what was happening because nobody could say this was what happened to this girl. Nobody knew anything. I was an immigrant within 1 year in Canada, and I was experiencing this. I had no family member here. They did the blood work, MRI, CAT scan, and they came up with total brain infarction, that all of my brain was infected from stroke that continued, that was a repeated action, and that affected all of my brain. That the only part controlling pulse was the one that wasn't affected yet. So after they discovered that, the next thing they could do was, because I was unconscious, was to place me on a life support machine. I was taken to the critical care unit, which is the ICU, and I was intubated and placed on life support machine from that moment for 3 years. I didn't come around. They kept doing every medical procedures possible. Nothing worked until someone referred me to a doctor in Toronto General that said they should do a blood test, a blood work, and I would come around. When I finally came around, I was quadriplegic. I was paralyzed both hands and legs. I couldn't talk. I couldn't do the. I was one that was doing everything for people as a nurse. Had to rely on people for common brushing of teeth, to use the washroom. I became an adult baby. I couldn't do anything myself. Eating was a problem. Speaking was a problem. It was devastating. After these events, my life completely turned around from being independent to depending on people. And in addition to that, I then had to just relax. I realized that thinking you are superhuman being was not possible. You just need to take a break and rest when you should. I ended up being able to do nothing anymore. After I recovered, after coming back after the treatments, I was taken for rehabilitation because of the paralysis I was experiencing. At a point, I was airlifted from Toronto to Vancouver for high intensity rehabilitation. That there I would recover completely. but I still did not recover completely there. By the time I left Vancouver, after a year, I still had left-sided weakness. Right-sided was improved. Right side was improved, but the left side wasn't improved. At that time, I already had my OHIP, but then I couldn't access rehabilitation. The government said I was a cold case. I wasn't really a case that was important to them to manage anymore. So I had to start paying with the help of my family, friends, and church. They were donating for me to be able to pay for rehabilitation out of pocket. This was difficult for me. There were days I wouldn't eat because I wanted to just make sure I had rehabilitation. This was a crazy experience for me. I don't wish anybody to have it. At this point, what I'm trying to do now is I'm trying to advocate for women. No woman should experience what I went through, especially if you have the papers, you should be able to access treatment, and nothing should stop you from being able to get the appropriate treatment you have. I still have left-sided weakness. I know it is as a result of not being able to access the rehabilitation I needed when I was supposed to access it. I hope no woman experienced the same thing I experienced from the from the neurological problem I had. And also, I've come to realize that we are not superhuman beings. We are mortals. There is life and blood in us. When we need to rest, let us rest. When we need to take a break, let us take a break. We are not robots. We are not ions. We need to rest. This is my contribution to the meeting. And this is why I've joined the crowning because I know we need to stand up for women's health. A woman should not go through what I've gone through at a tender age, not even as an old person. I was in my 30s when I experienced this. I hope this never happens to any other woman again. This is my story. Thank you for listening.
Thank you, Alu. A powerful story every time I hear it. A nurse coming to Canada, new to Canada, a significant life-changing event where you became from being very independent to very dependent, had issues with accessibility and affordability, and really looked to your community of family, friends, and your church to get through this. And I'm really happy that you joined our group and that you're advocating and sharing your story with others. So thank you very much. And we look forward to hearing from all of you again when we come back to our panel presentation. So is there any final words from Alu, Sudi, or Suman before we move along? Maybe you could all put your cameras on. Just as we say a big thank you. I see lots of positive vibes in the chat for your stories, so we're grateful for those.
Thank you for giving us the opportunity and to be part of this organization. Thank you.
Thank you, Simon. Thank you, Alu, and thank you, Sudi. So we'll welcome you to the panel. So our next, we'll move along. We have another poll. So here's the next polling question, number 4. If you are a person with lived or living experience, what heart, brain, or vascular diagnosis do you have? And you can pick multiple answers here. So we have coronary artery disease, or if you've had a heart attack, if you have microvascular dysfunction, sometimes we know that as MINOCA or NOCA. If you've had something similar to SUDI, a spontaneous coronary artery dissection, SCAD, a pregnancy-related heart condition like preeclampsia, diabetes, a cardiomyopathy like Suman talked about, heart failure, arrhythmia, valve disease, a stroke like Alu talked about, congenital heart disease, high blood pressure, or anything else. I'll give you a minute just to answer this poll. Okay, so it looks like a variety of conditions from coronary artery disease, heart attack, really a little bit of everything, some pregnancy, stroke, high blood pressure, and others. So quite a mix. Thanks everyone for answering that. So now we're going to switch gears a little bit, start the conversation, what everyone needs to know about heart and vascular disease. And I would like to welcome Dr. Shaheen Jaffer. And I'll just give a little introduction of Dr. Jaffer here. She's an internal medicine specialist in Vancouver and a very strong advocate and champion for knowledge translation in marginalized and ethnic groups in metabolic health, including women's cardiovascular health, in the South Asian community and in other rural communities in northern British Columbia or British Columbia. Uh, Her volunteerism pushes the boundaries from Canada to East Africa, the Middle East, and Central Asia. And a recognition of Dr. Jaffer's tireless and steadfast commitment to service and leadership. She's been the recipient of several awards, a few of them related to the promotion of women's health research or women's health education. And notably, she's recently received the King Charles III Coronation Medal for her significant volunteer contributions and service to Canada. So we're very fortunate to have Shaheen as part of our group and to deliver this presentation for you this evening. So welcome, Shaheen.
Thank you so much, Monica. Can you hear me and see me well?
Yes.
Okay, perfect. Hello, everyone, and thank you to the Alliance and the Crowning Leadership, Monica and Salima, for inviting me to present to you today on what everyone needs to know about women and heart and vascular disease. Because indeed, as you see their hashtag, her heart does matter. And it is indeed an honor and a privilege. Next slide, please. So we hope that by the end of this session, you will come to understand the landscape in Canada with regards to women's heart health. And some focus will be provided on how Indigenous and ethnic communities are particularly affected. As well, I hope that you'll be able to describe how heart and vascular disease, and vascular simply means the blood vessels in the body, can be different in women in terms of the symptoms, the causes, and sometimes treatment. And lastly, we hope that you will be able to utilize some simple methods and tips that we will share in order to lower your cardiovascular risk. Next slide, please. Now, first of all, we should talk about what is the issue. Heart disease is the #1 cause of death in women worldwide. And if we focus in on North America, as you can see on the graph on the right, and this is from a study published in 2019, the US is in sort of the green color and Canada is in red. The solid line there is women and the dotted line is men. But you can see that not only is the death rate increasing, the slope or the steepness of the lines is much more. They're more steep over the last 5 to 10 years. So what that means really is that the death rate or the mortality rate is actually rising much faster than it was a decade ago. In American men, there's also been a rise in the cardiovascular mortality, but not as fast. And in Canadian men, the mortality rates appear to have stabilized. Next slide. So let's talk now a bit about the cardiovascular health that can be different depending on your ethnic background. Some communities are more likely to have heart disease, not because of something they did wrong, absolutely not, but instead because of the many things like genetics, family history, even access to care and other socioeconomic challenges. And the 2021 Canada Census demonstrated that our population is becoming more diverse. Close to 10 million people identified as being part of a racialized group, and that's over 25% of the Canadian population. And this number keeps growing. The largest groups were people of South Asian, Chinese, and Black backgrounds, But as you can see in the chart, many other ethnic communities are also represented. Importantly, about half of all racialized people are women, which means the unique health and heart health needs of these women must be better recognized, understood, as well as much better supported than is currently being done. And that's part of all our responsibilities today. Next slide, please. It's actually a polling question. So, Monica, I'm not sure who's going to run this, please. Okay, there we go. So it's a single choice. So if the audience could please respond, that would be great. And if you prefer to self-describe as the last option on the bottom, please put your comments in the chat. Okay, so it looks like most people here today, I'm not sure if I can see all of the numbers. I see 6% are of Black background. Most are, looks like, of European descent, but there are people as well from the indigenous community, looks like the Middle East, multi-ethnic, and South Asian. So we've got at least, 15% of the attendees from ethnic or indigenous background. So that's great. Okay, thank you. Next slide, please. So when it comes to heart and vascular health, women are understudied, underdiagnosed, undertreated, undersupported, and underaware. And I actually have termed this whole situation under syndrome. And this actually comes from the Heart and Stroke Foundation report in 2018, which was very smartly entitled Misunderstood. It was really a wake-up call to all of us regarding the gaps and the challenges in women's cardiovascular health. Next slide, please. So let's focus now on risk factors. So we often talk about traditional heart disease risk factors like the teal box in the middle there, high blood pressure, diabetes, smoking, they're all listed there. These are well known in the medical field and in the general public. But what is less recognized is that these same risk factors can actually have a much greater impact on women when compared to men. And I will go over this particular aspect in another slide later. It's important to understand that women's heart health is shaped by two other groups of risk factors. On the left there, you have female-specific risk factors like pregnancy-related conditions, as well as preterm delivery, preeclampsia, gestational diabetes, polycystic ovaries, breast cancer treatments, as we heard a little bit about during the lived people's experiences, as well as early menarche and early menopause. These are important risk factors that are often not asked about when women present with cardiovascular symptoms. And then third pillar is on the right there, under-recognized risk factors, such as social determinants of health, including geography, ethnicity, indigeneity, and other conditions such as autoimmune disorders and mental health, like depression, and even chronic stress. These are very, very important risk factors that are often overlooked, and they can present either on their own or in combination. And many healthcare providers and the general public are really not aware of the full complement of risk factors a woman may carry. And so hopefully you will be able to show this graph if you want to take a snapshot to your healthcare providers when you meet them next, if you have any heart health questions. Next slide, please. So with regards to increased risk in ethnic communities, women of South Asian or Black descent have a higher risk of heart disease, high blood pressure, and also stroke when compared to Caucasians. Type 2 diabetes is also more common, and specifically for South Asian women, the risk of developing diabetes in pregnancy is 3 times higher. Moreover, cardiovascular disease, including stroke and death, can occur even 10 years earlier, so at a much younger age. And this is true for women and men as well. And particularly in Black men and women, MINOCA, or MI, which is a heart attack, myocardial infarction, occurs in abnormally functioning small arteries of the heart or arteries that undergo spasm, or if there's an tear in the artery. So the NOCA part stands for non-obstructive coronary or heart arteries. So it's not a big, large clot that develops and ruptures and then blocks the artery. MINOCA is other causes of heart disease. I must share and actually emphasize very strongly that in terms of heart attacks in women who have MINOCA, MINOCA actually occurs in women in only 10%. So only 10% of cases of what we call acute coronary syndrome or a heart attack or unstable angina you might have heard of. MINOCA only occurs in about 10% of cases, and in men it also occurs, but only in 3% of cases. So the vast majority of the time, a heart attack is from the coronary artery that is blocked by a large clot. And the obstruction is more than 50% of that artery. So there's more than 50% narrowing. I just want to emphasize that. While we may miss MINOCA, the most common cause, though, is the traditional, so to speak, heart attack that happens in both men and women. In East Asian communities, they tend to get heart disease after they've been in Canada for many years. And then they also tend to have more heart failure when it comes to heart conditions. Next slide, please. So what about our Indigenous communities? Indigenous women also have higher rates of heart disease, and their rates are rising as well. They have higher rates of pregnancy-related complications, such as gestational diabetes, hypertensive disorders, infections, and postpartum hemorrhage. And particularly concerning is the higher rates of maternal morbidity and mortality. Traditional risk factors are similar: high cholesterol, diabetes, obesity, and they under-recognized risk factors also include social and economic challenges, colonialism, rurality. Access to healthcare is much more difficult in remote and northern communities. Next slide, please. So heart disease risk can begin quite early in a woman's lifespan, from early or irregular or late periods to polycystic ovarian syndrome, depression, autoimmune disorders, pregnancy-associated conditions. And I hope you've all heard that pregnancy is considered to be a woman's first stress test, right? All of the fluid and volume and hormone changes can put quite a strain on a woman's heart. And even going and thinking about breast cancer treatment, certain drugs and radiation treatment can cause heart disease. And menopause, whether it's premature, early, or at the usual time. All these are risk factors for heart disease in women all across the lifespan. Next slide, please. So a little bit more detail now on how can pregnancy reveal early clues to a woman's heart health. Certain complications like high blood pressure during pregnancy, gestational diabetes, and preterm birth aren't just concerns related to pregnancy. There are very strong signals that a woman might be at higher risk for heart disease later in life, up to a 4 and even sometimes 8-fold increase in cardiovascular disease. And this is not only for the mom. Many people are not aware, but the children as well are at greater risk for heart disease, even in their adolescence, such as diabetes and high blood pressure. So that's why healthy habits, regular screening, not just after pregnancy, but before, during, as well as after pregnancy, are so important. Next slide, please. And one way for women to be in charge of their heart health before, during, and after pregnancies to document any complications and ensure that they're engaging in proper lifestyle measures. This is a tool developed by FIGO, which is the International Federation of Gynecology and Obstetrics. It's a great pregnancy passport tool, and maybe if you want, you can, take a picture of the QR code and have a look. But all of this will be available in the recording on the CWHHA website in about a week's time. Next slide, please. So the average age of menopause in Canada in women is age 51. And premature menopause is considered to be under the age of 40, and early menopause between 40 and 45. Now, the use of endogenous, and what we mean by endogenous is natural, or meaning that your own body produces this hormone. Endogenous estrogen protects the heart, and exogenous, or by tablet or patch or intravaginal, or even using progesterone. The use of these is really complex, and it really needs to be individualized in terms of using these medications. What I can tell you, though, is that women with premature or early onset menopause are at increased risk of adverse cardiovascular outcomes. And this risk can be prevented, again, if they have premature or early onset menopause. This risk can be prevented or mitigated by the use of menopausal hormone therapy. We don't call it HRT anymore, hormone replacement therapy. The proper term, the best practice term is MHT, or menopause hormone therapy. So MHT can be used in this situation until the average age of menopause. Now, we can use MHT for menopausal symptoms like hot flashes, as long as the woman is within 10 years of menopause. Because after 10 years, the risk of adverse cardiovascular events such as stroke, heart attack, etc., does increase. And be aware that at any age, MHT increases the risk of blood clots as well as of stroke. So this is an issue that it's really difficult to give any specific information, but it's best that you connect with your primary care provider to discuss this in more detail. Next slide, please. Now, I mentioned earlier that traditional risk factors pose a greater risk in women compared to men. So, for example, cigarette smoking. Tobacco use is actually the leading preventable cause of heart attack in women. Female smokers have a 3 times higher risk of heart attack than men. And if a person has diabetes, a woman with diabetes has an earlier risk for stroke, heart attack, and heart failure compared to non-diabetic women, and a twofold increased risk for heart attack and stroke when compared to men. High blood pressure is more common in women than men if they're over the age of 60. It is much less well controlled. Obesity increases the risk of coronary artery disease by 64% in women compared to 46% in men. And stress and depression, which I alluded to earlier, are unrecognized risk factors for women, increase the risk of a cardiac event by over 50% in women. Dyslipidemia, or high cholesterol, is significantly more risk-causing in women under 65 with regards to LDL. But if you have a low HDL or increased triglycerides, these pose better or stronger predictors of heart disease in women if you're over the age of 65. Next slide, please. Now, male and female hearts may look the same overall. However, the female heart is somewhat smaller than a man's, about 2/3 the size. And a woman's heart tends to beat faster, and our coronary arteries are also smaller. Importantly, though, these differences really also are in the way the plaque builds up in the blood vessels and causes coronary heart disease. And as we just talked about, women's hearts are also affected by hormonal changes, not only during menopause, but also during pregnancy. And that's why some risk factors are unique to women. Next slide, please. So both men and women can develop heart conditions that are similar, and these are listed at the top. So coronary artery disease, which is when you have cholesterol buildup in the large blood vessels of the heart, the vessels on the surface of the heart. And valvular heart disease, like when you have a very sticky valve or stiff valve or a leaky valve, and that impacts the blood flow from one chamber of the heart to another. And then arrhythmia, which means that you have an abnormally fast or an irregular heart rate. These are common in both men and women. But because anatomically we have different hearts, women can experience different types of heart disease than men. For example, our first person with lived experience had SCAD, or spontaneous coronary artery syndrome, or dissection, sorry, which is when there's a tear in the large blood vessels of the heart. Women are also more likely to have coronary artery vasospasm, which is when the blood vessels of the heart tighten and squeeze and limit blood flow to the rest of the heart. A woman can have microvascular dysfunction, which is the lining of the deeper, much smaller blood vessels of the heart become dysfunctional, either through changes in the wall of the artery, or they just can't expand anymore. There's also an entity called Takotsubo cardiomyopathy, or we used to call it stress-induced cardiomyopathy, where the heart muscle becomes weak. And this is very common in postmenopausal women. And lastly, peripartum cardiomyopathy refers to a weakened heart during or after pregnancy, or even like shortly after the baby is delivered. Next slide, please. Now, there are sometimes, not always, but sometimes differences in terms of signs and symptoms of heart disease in women versus men. Now, again, I must emphasize this. The majority of women and men will describe chest pain as their main symptom. So that's in the teal-colored, vertical triangle. So when they are presenting with heart disease or heart attack, they may describe their chest discomfort not as a pain, but they might describe it as a tightness or a pressure, maybe even like a heaviness or a discomfort. Women, however, which is the latter two-thirds of the graph here, women can, sometimes present as their chest pain as a burning, like a heartburn, or they may have nausea or, upper abdominal discomfort. These could be signs in women, more in women. I mean, men can have these symptoms as well. I've had patients who have heartburn. I have men who have had heart attacks who presented with heartburn. But more commonly, these symptoms happen in women. Women may also have upper back or, shoulder pain, or they have, profound fatigue, no energy, and weakness. Or also they might feel lightheaded or feel short of breath, unusually short of breath with simple chores and, not necessarily with exertion. Or they may also find that their heart is racing. These additional symptoms can be present. Women can describe 3 or more of these additional symptoms on top of their chest pain. But be mindful that not everyone's symptoms are the same, so please speak to your doctor or your nurse practitioner if you're experiencing any of the symptoms that we've mentioned just now. Next slide, please. In terms of stroke, stroke risk increases in women, in pregnancy, or if they have high blood pressure in pregnancy, preeclampsia, they're taking birth control pills, or they're using, hormone medication treatment. As well, if they have migraines, and migraines are also associated with other conditions such as Minoca. And then women who have an irregular heartbeat called atrial fibrillation are at more risk as well of having a stroke, although anybody with atrial fibrillation can have a stroke from that condition. In terms of the symptoms, on top of the facial drooping or the arm or the leg weakness, women tend to have more confusion or disorientation, or can also present with gastrointestinal symptoms such as nausea and vomiting as their symptom or sign for stroke. Next slide, please. So the first thing we need to do, how do we manage all of this? The first thing we need to do is by start making yourself a priority. Women tend to be, I share with my patients, women tend to be of type E personality, I say. We're everything to everybody every time, right? It's important that we take care of ourselves in order to take care of others. Just like you've seen in an airplane in the event of an emergency, the oxygen mask falls, and we needed to put it on ourselves first before we help our children or our family members or friends or anybody who's sitting beside us. Next slide, please. So how do we manage our risk for heart disease? The change we make needs to happen right now, right? If you haven't already. As soon as this webinar is over, I hope that you will start making these changes. Be active, keep moving. It may be difficult if you have arthritis or other limiting conditions, but do the best you can. Eat a variety of healthy foods, especially green leafy, vegetables. Manage stress as best you can. Stop smoking or don't start, including vaping. Significantly limit your alcohol intake and get regular checkups with regards to your blood pressure, your mental health, your cholesterol, and your blood sugars. And if you have any risk factors, don't hesitate to connect with your healthcare provider or even a family history of the same. Next slide. And even though, we may have health professionals to advise and guide us, the bottom line is that as much as 90% of the management of our health is done by us. Self-management is all about decisions and behaviors that we engage ourselves that affect our health. And when we practice self-management in terms of our health, we take our responsibility for our health and we act in specific ways that promote our wellness. So know your numbers, your blood pressure, cholesterol, and blood sugar. And, talk to your healthcare provider. Be preventive, be proactive in your health status. Next slide. So just some additional tips, when you go see your healthcare provider, prepare for your visit. Make a list of all your concerns that you want to talk about. Keep in mind, though, that you may have time only to talk about one thing. So make sure you prioritize the top 2 or 3 things you want to talk about. Know your medications. Bring your list of medications. I actually ask my patients when I'm seeing them for the first time to bring even their over-the-counter medications because these can interfere with your prescription medications. And use the 3 questions approach. What is my main health problem? What do I need to do? And why is it important for me to do this? What are the consequences? And don't hesitate to take notes about what you discuss with your healthcare provider. And this will help you remember as well what has been decided and what actions you need to take. Now, unfortunately, about 50% of people, next slide, please, they don't take their prescribed medication. And the Canadian Patient Safety Institute has created a list of top questions to help patients and their caregivers have a conversation about with their healthcare provider. So number 1 is, do I need to have any changes made, right? Same, increase, decrease, and why? And how long do I need to continue with these medications? Again, why? And am I taking them properly? And this might be something you could check with your pharmacist as well. And how will I know if my medication is working? How do I monitor? And what about side effects? How do I watch for those? And then the follow-up. Do I need any tests to see if these medications are working? And when do I book my next visit? Next slide, please. Now, when you are going, just some final tips as well. When you are going to see your healthcare provider, bring a trusted friend or a family member, again, who you can trust, with you to your visit. And they can help you take notes or ask questions. And don't hesitate to ask for definitions. Sometimes, the medical terminology can be confusing. So don't hesitate. Ask to be things to be explained in plain language. And you might want to quickly review again, recap so that, everybody's on the same page before you leave your appointment. And then, there's so much work done now virtually or electronically. Don't hesitate to email your healthcare provider if you need to. Next slide. So, in summary, then, cardiovascular disease in Canada is the leading cause of premature death and hospitalization in women. And remember those three pillars of our risk factors: the sex and gender, the traditional, and the under-recognized risk factors. And remember that cardiovascular disease in younger women, under the age of 40 is increasing. And unfortunately, women experience poorer outcomes following a cardiovascular event compared to men. There are much greater burdens and risks amongst women who are indigenous, ethnically diverse, or live in remote areas, or undergo challenges in socioeconomic factors, and women and gendered women as well. And so, really, what we need, and some of you have expressed this already, some of our people with lived experience, we really need culturally sensitive and ethnically tailored prevention strategies. We need more robust, more inclusive clinical research in women. And I'm really honored to, be a part of this group. And hopefully we can work together to actionize some of these, really urgently demanding goals that we have. Thank you very much for your time.
Hi, Shaheen. Thank you very much for that. Absolutely fabulous presentation. So thank you again. I would like to now invite our panel to turn on their cameras, which includes Shaheen and Deborah Baden, Dr. Naja Adrik, and Sadaf. Just wait till you have your cameras on. We're going now to our Ask the Experts panel discussion and Q&A. And we're going to invite also our three women with lived and living experience, Sudi, Suman, and Alu, because you have expertise and the lived experience of stroke and heart disease. And I wonder if we could just take just a minute. Suman, Sudi, and Olu we've met, but maybe the remaining panel members, and Shaheen we've met, but maybe the remaining panel members could just let our audience know who you are. Naja, would you like to go first?
Yes, of course. First of all, thank you so much for Janine and all the women with lived experience. Your story today was so inspiring, and set the stage why we are here, what you're doing in this organization. So my name is Naja Drake. I'm a medical doctor. My background in cardiac surgery, and I hold a master's degree from University of British Columbia. And I used to be the training representative for the Alliance, and this is basically me in a nutshell. Thank you.
Thank you. Deborah?
Hello, everyone. My name is Deborah Baden, and I am a registered nurse and a PhD student at the University of Toronto under the supervision of Dr. Monica Perry. My research is looking at hypertension in pregnancy among women of African descent, and it's an honor to be part of this conversation. And thank you to all presenters, Shaheen and the women with lived experience. Thank you for sharing your stories.
Thank you, Deborah. And Sadaf.
Hi, everyone. Thank you so much for inviting me to today's session. My name is Sadaf, and I'm a pharmacist by background, and I'm really looking forward to be a part of this panel. It's really great to hear all the wonderful stories and from these strong women.
Thank you. So we did receive numerous questions, and thank you to the audience for submitting the questions to the panel members. We received over 150 questions from participants, and we tried to categorize those into themes, about 18 themes to be exact, and they range from questions about SCAD and microvascular disease to menopause, arrhythmias, symptoms, mental health diagnostics, and more. To make this seem fair and inclusive, we selected sort of one question from each of sort of a compilation of themes. And they were really based, the selection was based on how frequently they appeared. So we tried to be a bit fair in selecting the questions. So maybe we'll just move to the first slide where we have the questions posed. So our first question is about SCAD, FMD, microvascular, and vasospasm. And the question posed is, how can someone tell if ongoing chest pain after a diagnosis is dangerous and when to seek urgent care? Sure, one of our panel members might want to tackle that one. Nausea?
Yeah. I can answer this question, and everyone else can like chip in to else. So I think this is a very common question, especially for women who are facing such a life-altering event like after SCAD or vasospastic angina. Sometimes chest pain can be longer, and you're always wondering if this is normal or something new happening. So I think the best thing to know, we really have this as one of the key messages of the campaign. When is doubt, check it out. But I think we need to pay attention if the chest pain is different from the one that you usually had, if it's longer, if it's heavier. So if this symptom, it's more alarming for you to seek medical advice, but you know your body best. So listen to your instinct. So if you feel something is off, it is not, you just go and check with the doctor. You're not emotionally or overreacting. It's your heart and deserve to get the best attention.
Thank you, Naja. Does anyone want to, Sudi, I wonder if you want to make any comment about that question since you have the personal experience of living with SCAD.
It is, thank you, Dr. Monica Perry, for that opportunity. It is very challenging because it is oftentimes the symptoms of SCAD are hard to detect, and often is only after the event has occurred that it's been diagnosed for most of the cases. But in terms of the, I would say, pain that's unusually outside of your scope, just like Dr. Naja just stated, would be in the realm. For me, my symptoms were unordinary, and it's not something that I experienced earlier. And this is prior to me knowing SCAD and SCAD in terms of being a part of the SCAD Awareness Alliance, among other survivors, is that every SCAD individual patient experiences it differently. Sometimes it does present itself in nausea, fatigue, all the other symptoms that have been identified earlier in the evening. So it is a personal self-investigation that one has to do to identify if this is within the norm range of my experiences or is this an outlier.
Thanks, Sudi, for that. Our second question posed is about menopause, menopausal replacement therapy. I think Shaheen, you recommended to us that we should refer to this in hormones. So how do menopause and hormone changes affect heart symptoms, and what should someone consider regarding HRT or MRT?
Do you want me to tackle that one?
Sure.
Okay. So it's the best of my ability, I will, because I'm not a gynecologist. But so remember again that we use hormone medical therapy, HMT, for two reasons. Number one is treating those very troublesome, postmenopausal symptoms. So the hot flashes and the memory fog. And as long as you are within 10 years of, getting into menopause, because otherwise your risk of heart events goes up if you use it after 10 years. So that's one situation to use. But, for those, what we call vasomotor symptoms, there are many other ways, other medications or, other lifestyle changes that can be used so you don't need hormone medical therapy to treat the vasomotor symptoms, anymore. There are other options. So that's important to understand. I think more importantly, if you do have premature or early menopause, then it's very important to go on hormone medical therapy so that your risk, and there's studies to support this, so that your risk of heart disease, because we want endogenous estrogen. I mean, you can't get it if we have premature menopause, but at least if you take it externally, there is evidence to support that you're reducing your risk of heart disease. So you take it until whatever, age 50 or 55, or, whatever your primary caregiver decides is best for you, because it will reduce the risk of heart disease, and it also will reduce your risk of other conditions you get in menopause, such as osteoporosis. And so I think that's sort of the best, I can answer that question. And I hope it helps, the audience.
Thanks, Shaheen. Next question is about arrhythmias. So atrial fibrillation is very common. That's an irregular heartbeat, fast heartbeat, and other rhythm issues. And a lot of these can happen around the time of menopause. But what should women know about palpitations or irregular heart rhythms, and when is further testing needed? Anybody want to tackle that question? Naja?
I can answer these questions. So yeah, so I think as you said, Monica, rhythm abnormality or atrial fibrillation is very common condition, but that doesn't mean that we should ignore them. So there's like having palpitation of fast heart rate is really scary experience. I remember this happened to me once in a gym, and I was like, oh my god, what do I have? So it's a very scary experience. But I think we should pay attention to it if it's last longer, if it's cause you any sort of fainting experience, near fainting experience, if it comes with regular rhythm. So I think at the time you need to pay attention and you need to check it out. So, and that's you just check with your doctor, and sometimes they need to do an ECG or Holter one to capture this abnormal rhythm. But I will say this: listen to your heart. You are your best, like unknown when it's abnormal, you know. And check with your doctor. Sometimes for the immediate, and sometimes they just get assurance it's something normal. But the bottom line is listen to your heart. And when things seems like abnormal, and this is like palpitation is longer or cause you any other symptom associated with dizziness, a near faint experience, I think you should seek medical advice. And I think Shaheen here can add to this.
Yeah, go
Sure,
ahead.
thank you, Naja. I agree entirely. And just a couple of other things come to mind is, if you're feeling your heart racing or thumping harder, or, I think what would really kind of raise for me some red flags are, okay, are you short of breath with it? Are you having chest discomfort with it? Are you lightheaded with it? Are you sick to your stomach? All of those things we've talked about that, women with heart disease have. So if that's happening with the palpitations or it's skipping, you'll know like this is not normal in quotation marks, then I would certainly seek medical attention, urgently. And there are many tests we have. We have something called a 24-hour monitor, like a Holter monitor that your, caregiver can put, on you. Or, if it's happening irregularly, there's now a device you can get from, Amazon or Best Buy. It's called a cardio mobile. And so if your symptoms of these palpitations are having not very regularly, then they're about $100, these cardio mobile devices that you carry with you, and you just put your thumbs on these two areas, and it traces your heartbeat. And that's for my practice, that has been very, very helpful for my patients to try and figure out, what is going on. So don't ignore it. There are many things we can do nowadays to try and figure out, what's going on.
Thank you, Shaheen. So the last question on this slide relates to exercise, rehabilitation, and physical capacity. So how can women know how hard they can safely exercise and what symptoms mean they should stop?
I can take this one, Monica.
Okay,
If
thank
that's
you.
all right. So I will usually when I talk to my patients and they ask this question very frequently that what is the safe way for us exercise? So I usually tell them something which is called talk test. That means that there are 3 different type of intensities that you can exercise. So there is light intensity, which means you're talking comfortably, you can breathe through your nose and you are feeling easy. So when you're doing that, that's your light intensity exercise. Then comes the moderate intensity where you can talk, but you cannot sing. So you're able to talk, but you're not able to pull like a full song or something like that. Your breathing is a little bit deeper. And then it feels a little challenging, but you still feel that it is doable. So that is your moderate intensity. And then there is a vigorous intensity exercise, which means that you can only say a few words at a time. You feel hard, but still safe. If you're feeling still safe at that time, that yes, it is, I'm doing a workout, but I still feel safe. That's all right. And your breathing goes stronger and fast. However, if you start feeling any kind of chest tightness, or you feel like a little bit of a dizziness, or if you feel like you cannot catch your breath and there is like a wheezing sound coming out, or your speaking become difficult and difficult, then those are the times that means that you should stop exercising, go to the cool down mode, assess your situation, and then go back to your exercise based on what intensity you can actually tolerate.
Thank you. That's very clear. So thank you for that. I just wonder if any of our women with lived and living experience might have you. All of you seem to have very uphill battles after your events, and I just wonder if there's any sort of 1 or 2 key takeaways you might offer to the audience. Sudhi, I see you on the screen. Do you have
Yes.
any sort of key messages?
Yeah, my key message would be one, redeveloping or re-engaging your self-efficacy is really, really hard when you are during the recovery phase, because something traumatic happened, and oftentimes we start questioning about our safety, or identifying everything as a risk. Having a support system in place, or developing a support system in place, that it lets you know that things are okay. And for example, for me, when I had my LVAD, I was scared of falling, because if I fell, I felt like, you know what, I'm going to die, because that is such a huge injury, considering the fact that I was on so many blood thinners. So fear of walking became a phobia of mine, something I would never have considered prior. Building the level of confidence in myself, and knowing that I was safe and okay, it was really took some time. And also really expressing those feelings with your physician, or whatever the caregivers your practitioner is, so that they can also let you know what is normal and what is abnormal, because everything gets skewed. Since your reality has been turned upside down, so have your fears and your self-confidence as well. That's my takeaway. And one more thing, if I may, I have noticed in the audience, one of my nurses, Teresa Ramfield, is in there, and I just want to say thank you. It is because of you and support systems and nurses like yourself that I'm still alive. So thank you for choosing to be a nurse.
Oh, that's nice, Sudhi. Oh my goodness. That's lovely. And thank you for that. I think fear and confidence, those are and having your life turned upside down, really powerful thoughts. Thank you. I'll just ask Suman, you mentioned your family as being very helpful to you. Any other tidbits?
Me, I guess just being positive, things come, all these complications happen, right? So just take it. I took it that way, as every day as a challenge, and come through. Again, good nutrition, try to be best change your lifestyle if you can, balance in everything, all those four pillars I taught, right? Exercise, good nutrition, good sleeping habits. I'm still have to work on it, working continue. And stresses, if we can manage our stresses comes every single day, but we have to see our health is priority. Please take care of yourself, as everyone mentioned. So
Thank you.
thank you.
Alu?
Yes, please. Thank you. Yes, I have something I'd like to share with the house. Is actually for the whole community, not just women. It is essential we have that person that can always follow up on us and say, I know this person will not do this. That was what rescued me. If it was that person that would just abscond from work and not just show up for co-op. They'll say that is what she does anyway. When she's ready, she will show up again. And that is how I would have just passed away in the sleep. And nobody would have known what has happened to me. So we should try in everything we do to be dedicated and punctual in our life. Let us set that standard that they can say no. Perry will not do this. Monica will not do that. Let that be our lifestyle. That is one. Then, secondly, the thing I would like to tell everybody, not just women, is that we need to hold on to our belief system. Because for me, it was the belief system that saved me in a way. They were already saying I was a vegetable. But I had family members that were strong in faith that said, no, I was not a vegetable, that they know I was still living and I lived. I remember the doctor telling my sister that she has come with African voodoo. Because when she used anointing on and prayed in Jesus' name that she would respond, and I responded, the man
I'm
said,
having trouble hearing you, Alu.
okay, I'm sorry about that. I can remember when sister came to check me in the hospital, and after they said I was already a vegetable, I said, no, she doesn't believe I'm a vegetable. She came with her Bible and her faith. At a point when she declared that in Jesus' name, I should move, and I moved, a doctor ran out of the room and said she was there with her voodoo, that she was there in the room with a voodoo. The
So
doctor did not believe it was possible for me to still respond. So I believe we need people that are of faith around us in any situation. These are what I want to add. Thank you.
thank you, Alu. Very important points. So let's, I see we've sort of toggled to the next slide. So a few more questions here. Medications and side effects. How do you know, this is a big one, I think. How do you know when medication side effects are normal or need adjusting? Sadaf, this is your question.
I'll take this one. Thank you, Monica. So it's normal to experience some mild side effects when you start a new medication for your heart condition or for your brain condition, such as like there is a light dizziness, light headness, or you have a little bit of a stomach upset as your body is adjusting with the medication. And usually it improves within a few days or maybe like 1 to 2 weeks. But if a side effect feels strong, or it lasts longer, then that means that you need to go discuss it with your physician or with your pharmacist. Now, I always bring this number because 95% of Canadians live within 5 kilometers of a pharmacy. In the evenings, your primary care physician may not be available. So if you're experiencing any side effects of your medication, your best bet would be to go talk to your pharmacy. If your regular pharmacy is closed at that time, you can take the list of your medication and go to any pharmacy that open and tell that pharmacist, and that pharmacist would be able to give you some advice. They will not be able to change your medication at that time, but they will be able to contact your prescriber, communicate with them, and help you with those things. Now, there are some symptoms that I would say require an immediate attention, like if you're having a chest pain, if you're having trouble breathing, if you're fainting, if you have like heavy bruising somewhere. If there is a mild bruise, you are on one of the blood thinners, you might will get bruised, like you hit your hand somewhere, arm somewhere, and you might get bruised. But if it is heavy bruising, then those are the things that need immediate attention, so you should get them checked right away. Work with your pharmacist. If you missed them, they did not talk to you about the medication side effect at your first point of contact when you were picking up your prescription, or if the prescription was delivered to your home, call them and ask them that I want to know what are the medication side effects that I need to look for, and what should I do in order for me to manage those side effects. So those are the things that would really help. I always say that we don't have to work alone. Like, we need to work with your healthcare provider. So if you're having a side effect, go talk to your pharmacist. If your physician office is open, go talk to them, and they would be able to help you out.
Thank you very much for that. Nice comprehensive answer. Thank you, Sadaf. Symptoms and what is happening to my body. How should women navigate symptoms like fatigue or breathlessness when tests appear normal?
I'll
This is a
take this
good question.
question.
Oh, thank you, Deborah.
Yeah. So it can feel difficult when navigating some symptoms when the tests appear normal. So in case any of these symptoms are severe, it's best to seek medical help immediately. However, there are some key ways that we could use to navigate the symptoms when the tests appear normal. For instance, it'd be helpful to keep a symptom journal. So document the symptoms that you are having to take to your doctor. Observe how you feel. How often do you feel fatigue, or how often do you feel breathless? And when do you experience the symptoms? Is it during an activity or when you are exerting yourself? For instance, do you feel breathless or fatigued when lifting an object, or when running, or going up or down the staircase? Or is it usually after a heavy meal? Do you have the symptoms after a heavy meal? Document the symptoms to share with your doctor. And it's also important, as you heard today, to advocate for yourself. Never stop advocating for yourself, because you know your body best. And what you've heard from today, and also from research, that there is evidence that shows that heart disease in women and women's health in general is under-recognized, understudied. What Shaheen would say, the under syndrome. So keep advocating for yourself. And what I'll share lastly is also to engage in self-care when navigating this period. Take some time to rest. You are not a superwoman. We all come with S on our chest because society has made it that way. We keep giving of ourselves and leaving little for ourselves. Please do engage in self-care and manage stress. You can engage in meditation or listen to music and having a healthy diet, and also have a sleep routine to care for yourself. These are what I can share.
Yeah,
Nika, can I just add one more thing? I know Olu's hand is up. I'm just going to quickly add another thing that also sometime you may be taking some of the medication that may be causing you fatigue or shortness of breath. They may not be the medication for your heart condition or for your brain health. They may be medication for something else. So if you have some kind of a mental health condition and you're taking some of the medication for depression or anxiety, sometimes they also cause fatigue. So it's always good to ask the provider, whether it's a pharmacist, whether it's your physician, to look at all of your medications and make sure that the fatigue or breathlessness that you're having is not because of any of the medication. Sleep is another thing that we often don't consider, but if you're not having a good night's sleep, that can really impact your day-to-day activity and you can feel fatigued. So keep an eye on your sleep as well. Thank you.
Thanks, Sadaf. And Alu?
I wanted to say apparently wasn't related to the message topic we are trashing. I had a question to ask Dr. Shefine. I had a question directly for her. My question was that she was talking about people with the people can have symptoms of ulcer, which could be related to heart attack. My question is, how does a woman that has gastric ulcer, differentiate the symptoms from gastric ulcer from cardiac arrest?
Do you want me to handle that now, Monica, or later with Olu?
Yeah, maybe just a general answer now, Shaheen, and we can
Yeah.
follow up on that for sure. Just
So,
because of timing. Yep.
yeah, thanks, Olu. So really, honestly, the bottom line is you may not be able to tell. So, you could have acid reflux, which you can have when you have an ulcer, whether it's a duodenal ulcer or a gastric ulcer. The only definitive way you're going to be able to tell is, of course, get investigated for heart disease and, whether it's you end up in the emergency and you get a troponin or whatever. But you may also need to have an endoscope, a gastroscopy. to actually look in your stomach. So often we have, to do both the gastrointestinal investigations as well as the cardiac investigations.
Thank you.
Welcome, Monica. I just wanted to add to that question about the fatigue.
Yeah.
Just like Sadaf had mentioned, and Deborah really articulated a good response as well. But I think with the add more to the fatigue, sleep apnea comes to mind, and that's why I think Sadaf was saying about the sleep. So remember, fatigue and breathlessness don't necessarily mean you have heart disease. It could be, things going on in your lungs, or it could be something called sleep apnea. So just keep a broad, open mind as to the causes of your symptoms. And again, just get checked out properly. Don't guess, don't second guess, is my message, I guess.
Yeah, good point. And really, the last question on this slide, and again, an important one, is mental health and emotional well-being. How common are anxiety and depression after a heart event, and what are the first steps for managing emotional health? I don't know who.
Can start with a little bit. Oh, Naja, I don't know if you wanna.
Yeah, go ahead, Sada.
So it's pretty common. I think some studies have shown that 20 to 30% people who have a heart event end up having some kind of anxiety and depression. And there are a lot of reasons for that. It's kind of a life-changing event. You went through a process, and that's kind of bring all that anxiety and depression. I always advise my patients that if they have an opportunity to work with like a social worker within their clinic settings, if their doctor is associated with a social worker, that is really helpful because then you can actually talk about some strategies that can help you managing that emotional piece of that health issue on daily basis. It's a big event that can change a lot of people's life based on the intensity. Sometimes people do have limited mobility, and that can impact your emotional wellness a lot.
Thanks, Sadaf. Naja, did you want to?
Yeah, I think Salaf give important like notes. I think first thing for any emotion to know this is normal. This is normal reaction to a life-threatening event that you have, and I think the best thing to acknowledge it and know this is normal. It doesn't mean that you are weak. As a woman, we tend to think that we have to be strong. We need to come back quickly to our routine and take care of the family. But acknowledge you have been through important events, and you need to take a time to go through it. And what you're feeling right now, it's very normal. And I think once we acknowledge the feeling, it's very important to discuss this with your healthcare provider or someone you trust, because sometimes it's good to just vent out this feeling, because maybe this is only what you need to have your feeling, acknowledge it, and heard. And secondly, I think starting like a small step, as Sudi and Sumreen was talking, like sometimes even walking become like a process that you need to think about, right? So I think start slowly, going through slowly to your regular routine, and take baby steps. And very important thing that even I saw in the chat, people talking about is rehabilitation centers. I think it's very important to be surrounded with people having the same similar experience and have the expert walk you through this process. You're not alone in this. So joining a rehabilitation center, talk with people that they have similar experience as you are. I think this is something that makes things much easier, because for many women, physical recovery is important, but emotional recovery may takes longer to tackle. And this is like my 2 cents on this.
Yeah, thank you, Naja. And Sudi.
Oh, yes, thank you. This is something that I myself have also underwent and tackled a lot. The biggest issue I find that really leads to the symptoms of anxiety is the fact that obviously one, we lose our confidence because of the event, and recovery takes a long time. It's one thing to have an incident like a really serious health incident and not survive and you don't deal with it. But once you do survive, it's as if you're dealing with a million pieces of glass on the floor and you want to piece it all together, but you don't have the energy, the capacity, and sometimes you look healthy, but on the inside, you're really still just starting your recovery journey. And one thing that has helped me and that I often would love other women to also take into account, is that when you look at it from not post recovery, but not seeing your life as a chapters of before and after, but rather as a continuation of I enjoy all these things prior to my health event. What can I do still? And really embracing that and looking at things that bring back the joy back in your life. And over time, the more you engage in those activities, the easier it is to deal with the depression, deal with anxiety, because you're not really just relying on medication. So sometimes medication is not the fix. The fix is perspective, like Suman stated, the 80-20. That's one thing that really got me through. And sometimes knowing what the fact that you're here still means you can fix it. Nothing is unfixable if you're alive, and we all can fix it. And since then, I've become a health coach, and when I saw that message that said women need women, we definitely all need each other. And a lot of times you don't really know that social prescribing is a type of healing journey that we can also get in from our community. Thank you.
Yeah, thank you, Sudi. Really important points. Thank you. And Shaheen.
Yeah, thank you, Monica. So yeah, it's amazing. I really appreciate all the comments that have been said so far, and I just want to reemphasize that mental health, it's like almost a double whammy, right? So, depression, anxiety are risk factors for heart disease. And, unfortunately, only 3% of cardiologists ask about depression as a risk factor. So I think the onus is on us, as healthcare providers, and more importantly, as people with lived experience to actually teach our healthcare providers. So I hope this webinar will help you all, empower you all to do that. But I just wanted to share that depression actually after an event is quite common. I would say about 30% of women, especially younger women. So again, it's something that we need to understand and manage, and about 15 to 30% of women get anxiety after a heart event. So it's something really, really important to acknowledge, and we do need more studies on that.
Okay, thank you, Shaheen. And maybe one final quick comment, Alu.
Yes, please. Actually, after recovery, depression is so high. I remember that in my own case, I was already getting depressed and I was already thinking of getting hypnotized because I lost my memory. I couldn't remember anything. I was already thinking of going to get hypnotized. Maybe I'll be able to remember things. I wake up in the morning, I'll just be crying. I wouldn't eat. I wouldn't take my prescription because I just felt my life has been shattered. So it is common with people that have experienced situations like this. Actually, it's difficult because we look at what we have been and where we are. It's like we are drawn back so much. And it makes, especially for people who are go-getters, it's difficult to agree that you are no more able to do anything. It can indeed cause depression to us. And maybe we may be able to benefit from mental assistance, psychologists, psychotherapy. Maybe it could help too in some situations. That's my last word. Thank you.
Thank you, Alu. So that obviously a very important topic, and the importance is to recognize that something is not right and speak to someone about that. So thank you. So I think we need to move on. I do see a fair number of questions. We've tried to address some in the Q&A, and maybe what we can do is sort of come back. I know we're going to send out a summary, and maybe we can address some of these questions in that summary just so we can sort of finish up, maybe just a few minutes past our time. So I'm just going to now go into the remaining slides, talking about care, what works, what can improve. So now this segment is really about hearing from you, the audience members, your experience in navigating heart, brain, and vascular healthcare. We want to hear a little bit about your health journey, how you felt along the way, and what could be better, because we are trying to make things better for women who live with these conditions. So to make this interactive, we'll be using a Mentimeter for some of the questions and Zoom polling for others. For the first two questions, we'll use word clouds. We'll see how this goes. Your input is anonymous in real time. I'll introduce a question or prompt. You'll respond on this Mentimeter using your device, and we'll just watch and see what happens in the word cloud. And then after that, we're going to quickly move to some Zoom polling questions. And I would just invite you to be honest and open as we've been here tonight. And, hopefully we will have some direction to inform future research, advocacy, and care innovations in women's cardiovascular health. Remember, there's no wrong or right answers. Every experience matters. So let's start our first Mentimeter. So here, you need to scan this code that should bring you to the Mentimeter. Yep, you're getting it. Okay, it looks like things have sort of stopped on this one. Obviously, the big words here are variable, grateful, thankful, privileged, blessed, and frustrated. That's very cool how this works. You think we should move to the next one? So, next question, what has been the hardest part of your care? Again, if you can scan and enter your responses. Wow, my emotional health, our very last point we spent some time on. Oh, silos. Awesome. Waiting. I am sure we could do this for a while and get a lot of feedback. These are really nice. Figuring out medications. Okay, thanks everyone for this. I think we should sort of pause on this one. This is great. So how has your care been for your heart, brain, or blood vessels? Very good, good, okay, hard, very hard, or prefer not to answer. Oh, nice. It looks like 66% rate their care journey as good or very good. Next question. Have you had problems getting care? Yes, some problems. So about 60% have had some or many problems. So obviously there's work to be done. So that's why we're here, I think, is really trying to make a way forward for women's cardiovascular health. So What needs to get better? Faster, more correct diagnoses, which we know is a bit more difficult in women, easier to see a specialist, more help with mental health issues. So thanks. These are really good takeaways. Last question. How do you, and then we'll just do some summary slides and wrap up. So thanks for hanging in. How do you feel about your condition today? Okay, but still learning. A few of you are confident about 1/5. So thank you for that. Final thoughts. We do have sort of a call to action. How can we stay connected? How can we link you to resources, sign up links, etc. So I'll just walk through a couple of these slides. So I would urge you, I mean, we can't do this alone. Crowning Us is very much working in collaboration with the Canadian Women's Heart Health Alliance, and a top-notch sort of organization. I would urge every one of you to join the Canadian Women's Heart Health Alliance. It'll help your voice be heard. You'll build skills. You'll connect with others, influence national projects such as this. And your participation is really flexible depending on your time, your conditions. So I would urge you to join. So we'll just go to the next slide. I'm sorry, I'm going to have to run through these quickly, but we'll do some sharing of these. So here are some resources for you. The Canadian Women's Heart Health Alliance. They have a program where Red Canada is February the 13th of 2026. Many resources, multilingual key messages and other resources. There's a Canadian Women's Peer Support Heart Hub. There's the Canadian Women's Heart Health Center with infographics, questions to ask your healthcare provider. And in our presentation today, we heard from Shaheen about that. There's the Women at Heart Peer Support Program. And then there's the University of Ottawa Heart Institute that has the top 10 tips for healthy eating, managing stress. They have webinars and they have a risk assessment tool. So this is the advocacy part. We see nausea here on the right, where Red Canada, again, it's on February 13th. I would, if you want to get involved, please join. Really making headway, I think, in this and helping really increase the awareness about women's heart and stroke health. This again, I'm just circling back to Crowning Us. We are really trying to push to have all voices of women heard across Canada, not those from underserved communities. We will develop resources. That's why we're doing this, to try to determine where there are gaps and what we can do next to help improve outcomes for all women and women youth broadly that live across Canada. So just acknowledging our planning committee. Everyone is listed here. I'm not going to read, but we are all working together to help amplify the voices of women living in Canada around heart and stroke health. So again, I would urge you, if you want to stay interested, to please join us in February for our workshop. It tentatively looks like it might be the 19th. Similar sort of session, 6 to 8. So please keep an eye on your email for more information about this. And that's it. So I would urge you to complete the evaluation form that you'll receive. You'll get a 15% off for the Wear Red Canada online store. And you can reach the evaluation form by scanning this QR code, and I'm sure we'll probably send that out to you as well. So anyway, just thanking everyone for joining. A super good session. Apologies for going over, but I think the conversation was good, and really thank you for hanging in there.